Okay, I'd like to go ahead and get started. I'm sorry to interrupt you. It was extremely rude of me. But because of the hour and the presentation beforehand, what I'd like to do is to just walk you through some things that are supposed to happen later this year as far as some things I think that are going to cause us some concern as far as gram-negative susceptibility testing. The first thing I would tell you is, and Dr. Frank would probably agree with this, that resistance is futile, as the Borg have taught us, for those of you who've watched Star Trek for probably most of your life. I think if you've watched them, you know that the Borg, they assimilate, they adapt, and I think in many ways bacteria must be like the Borg because they are able to assimilate DNA and they adapt. We end up losing the battle sometimes because of antibiotic resistance, and the talk that you just heard was talking about HIV resistance. So we do have issues with all these different life forms as far as our ability to control them. So I'll start you with a case. This is a 56-year-old woman who's been in the hospital for 4 days for the treatment of metastatic breast cancer, and she develops a fever and shaking chills. She has 2 sets of blood cultures that become positive, and it's reported back to you as being gram-negative bacilli. They put them into an automated machine, as you can see, and shortly, probably about 24 hours afterwards, they report to you that she has Klebsiella pneumoniae bacteremia. They also give you the susceptibilities, which look like this. You're, of course, excited to see these results. Life is now uncomplicated, right? Unfortunately, life becomes complicated. There are 2 things I would point out to you. The first is under the MIC column, and then the interpretation. Most people go to that column first, right? You're looking for either S, I, or R, particularly S or R. But I think a lot of times we forget to look at the MIC because it'd be nice to know where in that susceptible range are we. Are we over on the left-hand side of it where things are exquisitely susceptible, or are they kind of in the middle, or are they very close to that break point? Would be nice to know. So when you look at this, what do you see? Okay, now what do you think about the bottom? That the automated ESBL test is negative. So we have some discordant data. Have you ever seen something that happens like this before? Yeah, they have the Vitek 2 that has the expert system on it. Yes, it's the same thing that our VA uses as well. So you see a little discordant data. You see a lot of cephalosporin resistance, as you said, susceptibility that looks like it's going to be reasonable to try either an aminoglycoside and the carbapenem antibiotics, and you see imipenem and meropenem listed on there. So now what? What would you pick and why? And again, why is this an ESBL negative, or is it truly ESBL negative? And I think that, we've already talked a little bit about that, but these are the things that we're starting to see more and more. And the questions and concern, I've seen a few that are exactly like that, that ESBL by automated testing is negative. But when you look at the antibiogram, it's extremely concerning that it probably is an ESBL. So what I would tell you, the first thing is antibiotic susceptibility testing, the way that it was taught to me, is it's a best guess that the drug you're going to pick will be effective against the bug that you are growing. And then an MIC is basically a best guess with a decimal point. These are not absolutely perfect. Just because it says susceptible doesn't guarantee you 100% of the time it's going to work. And just because it says resistant doesn't guarantee you it's always going to fail. From some studies done in the past, even things that were resistant still might have up to a 50 to 60% chance of succeeding in the right circumstances, obviously, and in the right patient. But 60% chance of something being affected versus over 90% chance, I think I'd rather opt for the second choice instead of course, some people would ask which one's cheaper and go with the cheaper one at 60%, but I don't like to gamble. I would prefer to use the most potent agent that I can, and obviously if all things are the same toxicity and cost-wise, that would be my choice. We know that there are a lot of different mechanisms for antibiotic resistance, and this is just a list of the most common things that you see on there with membrane impermeability, things not getting through the membrane. And with gram-negative bacteria, remember that there are these little small holes that are called porins. Some of these porins can actually change the canal size through them, or the diffusion channel through the porins. The other one that we're learning more and more about, even with some gram-negatives, is efflux, which is similar to reflux almost. If you eat something and then you feel it burning, you know that it's not all staying in your stomach. Some of it's trying to get back up into your esophagus, and in many ways, what you see with efflux is another resistance mechanism where that enzymatically bacteria can pump the antibiotic out. Many times, if you calculate the efficacy of the pump, it might be as quick as it gets in, or sometimes the pump is even more effective than the ability of the drug to get in. So it decreases the amount of antibiotic intracellularly so that usually it can't get to its target in adequate concentrations. Albeit, though, if you give an extremely potent antibiotic that gets significant concentration, do you remember the film, The Perfect Storm? And they had that nice picture of this huge wave and the ship that was right up at the top of it. I think if that was the amount of antibiotic, there's no way you're going to keep the water out of the boat or out of the ship, I guess. So it depends. Some of these you can override the pump and still have efficacy, but sometimes you can. Inactivating the drug by one of the things you see listed as beta-lactamases. Alteration of the target, you see by a lot of different things, either ribosomally, cell wall precursor targets like penicillin binding proteins that have now been changed somewhat, so the target has changed. Some of that also happens at the ribosomal area. The target enzymes, like beta-lactamase inhibitor resistance, so even some of the things that should be binding to some of these beta-lactamases aren't as effective anymore. Overproduction of target enzymes and other things like oxytrophs that bypass the inhibition steps, and you see that more with trimethoprim sulfur resistance. So this nice graphic, I think to me, looked like the cut side of a piece of carpet. Although probably it's pretty close to what the side, if you cut through a gram-negative bacteria, would look like. You do see things that make up lipopolysaccharide. You see lipid A, and you see the space in between the outer and inner membrane, and then the periplasmic spaces where that you see beta-lactamases being accumulated, as opposed to with gram-positives, you see them kind of flung out into the environment and hopefully staying relatively close to the surface of the bacteria. And that's kind of the challenge, is getting things into, because the targets are in the inner membrane. So when you're looking at binding, as cell wall active agents do, so what are we talking about? Penicillin, cephalosporins, carbapenems, monobactams, etc., all bind to these penicillin binding proteins, or the enzymes that structurally put together cell walls. If you can inhibit penicillin binding proteins, you cause structural defects in cell walls, and many times the bacteria can't survive that. So it's getting these drugs in. It depends on the size of the drugs. It depends on the porin size. And it depends on efflux. So there's a lot of different variables with this. And as I'd already mentioned to you, even getting into things like Pseudomonas, where we hadn't really thought too much about it in the past, we've uncovered that there are efflux pumps that work quite efficiently with Pseudomonas. And this cartoon is looking at imipenem and meropenem getting through a porin, but the efflux pump pumping meropenem out quite effectively, but not really tagging and pumping out imipenem quite as efficiently. So out of all these, really, because of the time, and you could, as people do, talk for weeks about this, and you can go to ICAC and IDSA, and these are long symposium discussions. The thing I'd like to talk about this evening is just enzymatic inhibition, or beta-lactamases, because those are the things we're seeing more commonly, and those are the things that we worry more about now, especially in this day and age. Obviously, beta-lactamase enzymes are produced by living bacteria, and they're either chromosomally or plasmid mediated or plasmid determined. A lot of these started out just being chromosomally. That's where that they were first noticed or first found. But being bacteria, they've become quite astute at making sure that they have other alternative pathways if one pathway of resistance gets blocked. We talked about them being excreted outside the cell wall or in the periplasmic space. These are, I know there's well over 100 different kinds of beta-lactamases now, and it becomes a little concerning trying to remember what does what and which are associated with which antibiotics, and that remains relatively confusing for a lot of us. Also, that the question about where did beta-lactamases come from, I think is not clear, but there has been discussion and a little data that perhaps they evolved from penicillin-binding proteins or cell wall precursors, and the bacteria found that these actually would bind to beta-lactam, naturally occurring types of beta-lactam compounds, and would inhibit the activity of those in cell walls. But the ones that we're worried the most about are the extended spectrum beta-lactamases, and these can arise just from a single mutation of one amino acid. So one amino acid substitution can now take you from a relatively narrow to a very broad spectrum beta-lactamase. So before we go, I just wanted to refresh your memory a little bit. In the article that I handed out to you, actually this is taken from the Jacobi and Munoz-Price article in New England Journal in 2005 in the glossary section, so nothing for you to worry about having to write down for those of you who like to write a lot. The first is AMP-C beta-lactamase, and it's a broad-spectrum enzyme that was one of the first ones that was actually discovered. And when they noticed this, it was in individuals who were given ampicillin that seemed to fail. They thought this was chromosomally mediated, and that's hence the AMP-C part. But we know that AMP-C now can be not only chromosomally mediated, but plasma mediated. So it's adapted into other transmission modes. It's also seen active with cephalomycins and oxyamino beta-lactams. And if you're not sure what cephalomycins and oxyamino beta-lactams are, they're also in this. And it's important that you recall what beta-lactams fall into which groups, because it'll make understanding resistance a little easier. Most of us know about beta-lactam, beta-lactamase inhibitor combinations, antibiotics that are paired with either clavulanic acid, sulbactam, or tazobactam, and basically using those to hopefully bind to the beta-lactamase that's there, if it can, and inhibit the beta-lactamase, and, if you will, restoring a lot of the natural susceptibility to the parent beta-lactam. Carbapenems, I think most of you know about, that these are basically structurally very similar to cephalosporins, except that there's a replacement of a sulfur with a carbon atom, and the ones that are in here, and this is not a complete list, is imipenem, meropenem, and ertapenem. And cephalomycins are represented by cefoxitin, cefotetin, and cefmetazole, which all these used to be available, and then we've had varying problems getting these over the years, especially with cefotetin when it went off patent and now is back onto the market again. Other things just to remind you, we talked about ESBLs, but this name realistically evolved because of those changes that we saw with some of the earlier precursors of beta-lactamase enzymes. And then you see these names like TEM, SHV, and OXA, so TEM, as some people say, SHIV, which might want to send a shiver down your spine on some of these resistance patterns, or OXA. Some of these will clue you into what antibiotics that they may be resistant to. Some of them you have no idea of what the association is unless that you look at the literature and learn it. It also now includes things, so CTX is cefotaxime, so even some cefotaxime resistance that you see occurring. So all these fall into this extended spectrum beta-lactamase. So it started that kind of narrow, and the bacteria got wise, able to change some of the prior beta-lactamase into these broader, more potent, if you will, forms of enzymes. The inhibitor-resistant ones that you see are the ones that get no additional efficacy by adding either clavulanic acid, sulbactam, or tazobactam. Can you think of a bacteria that might fit into this, where that you get really no additional efficacy by adding either clavulanic, sulbactam, or tazobactam? It's somewhat similar to the color in the bar at the top, since it produces pyocyanin. a green pigment, Pseudomonas. You know, when you look at it, if it's resistant to piperacillin, it doesn't seem to be any more susceptible to piptazo. So again, that's when you start looking at inhibitor-resistant beta-lactamases. The inoculum effect, I think most of you know that the more bacteria that you have, the more the chance you're going to find a mutant that's resistant to the antibiotic. So if it was a smaller inoculum, if it was 10 to the 5th, you might not have any resistant mutants. But if it's 10 to the 11th or 10 to the 12th, you might have 2 or 3. So when you use an antibiotic that would cover most of the wild type but not the resistant mutants, you select out the resistance. And if you stably de-repress that, now it becomes the most prominent bacteria that are there, and your antibiotic quits working. I'm really not going to talk about integrons. It's there for you to read later on. I'm sure when you go home and you're totally enthralled by the discussion and you just can't wait to read this article. Monobactams is actually an abbreviation. There's only one commercially available. It's a monocyclic beta-lactam. The only one that's out in the market is, guess which one, which is listed for you on here, Astrianam. It's actually called an oxyamino-beta-lactam as well as a monobactam. Most of these oxyamino-beta-lactams, though, are what you would see with some of the, quote, third-generation cephalosporins, and include cefotaxime, ceftriaxone, ceftazidime, and actually cefepime, even though they call cefepime a fourth-generation cephalosporin, because of some of the inherent changes or differences that cefepime has versus ceftazidime, and some of it has been touted as this Witter ionic effect and kind of charge neutrality that this antibiotic has versus some of the others. And plasmids, I think you probably know quite a bit about plasmids. The last one, I'm not going to talk about transposons either, but those names that you saw before, SHV, TEM, OXA, M, VIM, KPC, what I would tell you is what's bolded here is beta-lactamase nomenclature is not standardized. It's a mess. The only one that kind of made any sense was TEM, and it was the first 3 letters of the last name of the patient where this was initially detected, and that was Temanera. So a little bit of trivia if you want something to break the ice at parties, there you go. The rest of them might make some sense if you think about CTX as cefotaxime-resistant OXA. Which drug do you think that might be? Oxacillin, right. IMP, imipenem. So those make sense. So, you know, their ability to hydrolyze cefotaxime, oxacillin, and imipenem. VIM is Verona integron-encoded metallobeta-lactamases, which is something that we see daily, right? We might. But getting into this whole realm of metallobeta-lactamases, which are somewhat involved in now getting into the KPC is Klebsiella pneumoniae carbapenemases. So carbapenemases we've heard a lot more about. This is a huge problem in the northeastern United States, and it's slowly been going elsewhere in the United States as well. The bottom line here is the bottom line, that the origin of the names of other beta-lactamases is extremely variable and very arcane and tough to keep up with. So people have used kind of a if you will, a branching tree or looking at what's related and what's not, and this is the way that it kind of used to be, but this has even changed now that you see on these beta-lactamases, that the type 1 beta-lactamases used to be chromosomally mediated. Not all of them are anymore. And the ESBLs were over-plasmid mediated that you see. But when you start thinking about ESBLs, what was that mnemonic that most people thought about in the past? Yes, people who are astronauts, or perhaps if you watch the Food Network would sprinkle on food. Either one. As everyone now is totally worn out from the past talk. Space and spice bugs. So, you know, thinking about those were most commonly associated with ESBLs. But we're seeing a little bit of changes now when we're looking at some of the other beta-lactamases that have come onto the stage for us to deal with. And just to give you an idea of the evolution, this started back in 1968 by Sawai et al.'s description of trying to break this down into substrates, either cephalosporins or penicillins. So you had a penicillinase or a cephalosporinase, and it was relatively rudimentary in our understanding. By 1973, Richmond and Sykes came up with their first classification, of which they had 5 major groups. Then people started looking at it, noticing some things were not that much different, some things were a little different. So Sykes and Matthews added a little bit more into this by trying to differentiate these enzymes by their isoelectric points, and that helped a little bit. But then Mitsuhashi and Inoue looked at adding one additional thing to it, and that was cefuroxime hydrolyzing beta-lactamase. But Catherine Bush was credited with going back and relooking at all this and really starting to put a little bit more of an idea behind really getting these separated and trying to make it a little bit easier. And by 1995, Bush, Jacoby, and Medeiros had the now what's regarded as the Sentinel paper of really looking at and describing beta-lactamases. So they broke it up into 4 groups, and basically what they were looking at was something similar to this, which I'm sure will probably appear on your in-service exam next time. It'll be one of those mix and match, one of those fun things, or hopefully not. There is a key that you see. The C is chromosomally mediated, the P is plasma mediated, and as you can see, it's really kind of confusing. Not a whole lot makes a whole lot of sense when you just look at this table. And so we don't really know a lot of the resistance just by saying, well, is it a carbapenemase, et cetera, but we know it by looking at the antibiograms when we're looking at a lot of these. So we know with ESBLs and a lot of the other things we talked about by trying to get some ideas and looking at the antibiotics and figuring out what might be going on. Now, what you see is a plate, and the disc that you see on the plate is cephalosporins. On the left-hand side is E. coli. It's a wild type. On the right-hand side is the wild type, and on the left-hand side is one that's described as being an ESBL producer. Can you tell the difference? Look at the zones of inhibition around on the right-hand side around the top and bottom cephalosporin disc, and you actually get a little bit of a bleed over here where both of those are diffusing through the agar, and you even get a little bit of susceptibility here. You're seeing very little at the top, and at the bottom with a little lower concentration, no activity at all. So that's already telling us there's something that's not going to work if you use cephalosporin to treat the isolate from the patient on the left. It has a good chance of not working. Problem is that we have a lot of different ways of looking at antibiotic susceptibility testing, and you see pretty much a lot of those listed here. You have E-test, microscan, you have the Vitek, Vitek 2, and others, as opposed to just doing Kirby-Bauer antibiotic susceptibility testing, dropping the discs on a plate. The problem is dropping discs on a plate is really time-consuming, and it's much easier to put these isolates into an automated machine. While they're running, you can go do something else and have more efficiency with time. And the problem that a lot of our laboratories have now is getting enough techs who are really good and talented to be working. So we are using more and more automation, and sometimes that may not be the best thing for us because the results tend to be somewhat confusing. One of the interesting articles that came out, now this was back in June of 2001 by David Patterson et al., and you see some individuals who do a fair amount with resistance testing, and that's Bob Bonomo and Lou Rice that are at Dr. Heinzel's old stopping ground up at Case Western and at the VA that's there as well. And they wanted to look and see, and you see this is many years ago now, but they wanted to look and see if you use cephalosporins, would they work against extended spectrum beta-lactamases? So what they did was they looked worldwide to try and find where in the literature people had actually looked for this, and there wasn't a huge amount of data at that time. What they did for many countries, and they had to parse through the data, and some were not valuable for this. But you see it was a small number of individuals, about 24 individuals who ultimately were looked at with this, and they looked at the chance of them failing therapy, depending on the MIC, or dying. Now, one of the things that I think is interesting is, and if you look at with all this treatment or failure, the break point at that time for ESBL positive organisms with cephalosporins was less than or equal to 8 microgram per ml. You see with an MIC of less than 1 that there were 3 people that failed and 2 that died. These were not realistically because of antibiotic issues. There were some people who failed therapy because that they didn't have an abscess drained, or that they just didn't get good control for a variety of different reasons, but not because of antibiotic resistance. But when you start going up the chain, you'll see, as the MIC starts going up, even though these are small numbers, by the time that you get to an MIC of 8, everybody failed therapy. 6 out of 6 failed, and 2 out of 6 died. So this really made people take a step back and look to say, cephalosporins, even though they in vitro look like they should work, in vivo don't look like they work very well at all, especially at higher MICs. So basically, this was one of the articles and other data that came out that said to the microbiologist in the lab, if you have ESBLs that are either E. coli, Klebsiella, Proteus, you need to report these results, no matter what that this truly says, as being resistant to all the cephalosporins and aztreonam. The only exceptions are the cephomycins. And which ones are the cephomycins? Cefoxitin, cefotetin. Now, isn't it interesting that these seem to work in the laboratory? How many times have you used cefoxitin or cefotetin to treat an ESBL? Anybody? Not me either. Very, very few data are out there with trying to use the cephomycin group. And I think we're just anxious about the cephalosporin class altogether. And I think even though these look like they should work, I'm not aware of any large numbered prospective randomized studies looking at this. So when you start looking at how do we look at susceptibility tests then, a lot of labs don't even attempt to detect ESBLs other than in E. coli or Klebsiella. And remember, we talked about space and spice bugs, so a lot of these aren't really being reported as ESBL producing necessarily. Which ones do you test? Well, some laboratories are able to do this double disc diffusion, so you put a disc in the middle and other antibiotics on the side, and if you start seeing some susceptibility growing towards the center, that would be something that would be reported out as susceptible. But you see with the disc on the top, really no activity at all, which would be reported as resistant. The problem is that the group that now does Breakpoints, CLSI, really didn't have guidelines available for testing other organisms, and that was a big bone of contention. So this is from Dr. Schreckenberger, who was nice enough to send out to a lot of us a discussion about, since he attended the most recent CLSI meeting, and the thoughts and what we probably are going to expect to see. This was some of his data up at Loyola University. And this is 2006 and 2007 data, and one of the things you see is with his Citrobacter cocerii, that out of 110, they had 6 were positive with a percent of 5.5% ESBLs. The next one was an Enterobacter cloacae at 5.2% ESBL production, and the numbers get even more intriguing. 5.7% with Morganella morganii, Proteus mirabilis at 4.2%, and then Providentius stewarti at 12.5%. So there's a lot of things that we may or may not be made aware of. The other thing is, with laboratories, they send out an unknown bacteria, and they do that for CAP credentialing. Hopefully you get the organism right, so you can identify the organism, and then they want to see if you identify the susceptibility correctly. There's been a lot of variations, a lot of issues using automated systems. What they sent out was the Citrobacter frundii that was an ESBL producer, and its MIC was 16 microgram per ml. When they sent it out to laboratories, what they looked at was what system did they use. The second column was the reported cephopime MIC or zone in the susceptible category, and then what was the modal MIC. So you see with the BD Phoenix system, not that many people using it 24, and they didn't really report out an MIC. And their modal MIC, though, that they did report out was greater than 16, which would have been pretty close to what was sent out. Microscan, 15% were reported to be susceptible to cephopime, but their modal MICs, it wasn't many of those, as you can see, and the modal MIC was 14. But the Vitek and Vitek 2, most of them reported out that it was susceptible, and the modal MIC was less than 4 or 2. When you looked at disc diffusion, 34% reported it out as being susceptible with a modal diameter around the disc of 15.5 millimeters. So again, things, depending on which system you use, could be all over the place. And it's not that any of these is necessarily always consistent. So this has been a real problem for CLSI and trying to grasp at this, and what do we do about this? Since these systems aren't all that great necessarily picking up ESBLs, How do we accommodate for them? So they're looking at revising breakpoints for cephalosporins, and that was part of this discussion that they had not too long ago in Tampa, and coming up with something that would be useful to clinicians to hopefully take a little bit of the guesswork out of this. So what's been recommended, you see from 2009 to 2010 recommendations, you see the agents on the left-hand side. So the breakpoints less than or equal to 8 susceptibility all the way down for all these, resistant being greater than 32 with cefazolin and greater than 64 microgram per ml for cefotaxime, ceftazocime, and ceftriaxone, and then back down to greater than or equal to 1 to 32 with ceftazidime and aztreonam. What's proposed from this year's meeting was to significantly drop those breakpoints. So going from a less than 8 to a less than 1 being susceptible. Resistance would be greater than 4 all the way through cefazolin down to ceftriaxone. Ceftazidime basically only had 1 dilution decrease and aztreonam 1 dilution decrease. Now, this is going to be quite interesting because it's trying to take, if you will, kind of a little bit of the monkey off of our back and making a decision. But there's another side of this that's going to be really tough to deal with, and that's the infection control aspects. If you want, and this, what I'm going to do is to put this into a PDF file so I can send it out to you because this is in Keynote and a little large. But you see the breakpoints that have changed, at least in the disc diameters as well. Things that were evaluated but not revised: cefuroxime, cefepime, cefotetin, and cefoxitin. So those all stay the same breakpoints. But again, how many of us are really going to use cefotetin or cefoxitin? And cefepime, again, with that less than or equal to 8 as the breakpoint, really didn't change. So do you need to look for ESBLs when you're testing for Enterobacteriaceae? And the thought from CLSI was said, no, for patient management, tests for ESBLs aren't really going to be necessary with these breakpoints. But if you want to get an ESBL for infection control, that's fine. You just have to ask micro to do it. Well, I'm not sure what's going to happen once they change the breakpoints, and then they're going to say, which ones do you want? And I think, you know, it's going to be really kind of difficult to look and say, I want which ones of these. And I think we're all going to have to look for guidance of which one of these could be ESBLs. So looking at old versus new, and basically for patient management, they don't think that it's really going to make any difference to do ESBL screening or edit the S and R for cephalosporins, penicillins, and aztreonam, because that's all going to go away once you really drop those breakpoints. Because what used to be susceptible up here now is going to be down towards the table. It's going to be really low. When you look at infection control, this is where it's going to, I think, be more difficult. And how is micro going to accommodate us when we start asking for this? So there's been a lot of discussion, and I think some of it's going to be quite interesting to see what the final word is on this and what we have to deal with. There is, again, data that looking at published reports of clinical failures when patients are treated with cephalosporins and have MICs in the susceptible range, but the organism turns out to be an ESBL, as you saw that data. But some cephalosporins weren't changed, like cefepime. But I would ask you, if somebody had a Klebsiella pneumoniae bacteremia and had an MIC of 8, would you put them on cefepime? So we're going to have to really look at the MIC. If it's an MIC of 1, I don't think anybody would hesitate. But at 8, you're right almost at that break point of having intermediate susceptibility. And for bacteremia, and really, you know, about a third of people with Klebsiella pneumoniae will be bacteremic. So this makes people quite anxious. The problem is that MIC testing is not 100% reproducible. It's not uncommon to see one dilution, if you will, or a doubling dilution difference. So an MIC of 4 redone could be an 8. So again, you know, it's a best guess, if you will, with a decimal point. Some of these results are definitely inoculum dependent. If you use a microscan MIC panels, whether that you use the standardized system, the BBL prompt system, or turbidimetric, whether you put a little bit of the isolate into a tube, you vortex it, you put it in a spectrophotometer, and will measure and tell you with a certain amount of deflection whether it's at a 0.5 McFarland or not, which is the standard inoculum for most things. Does that make a difference? And some people say yes, and some people are saying, well, maybe not. So if you just eyeball the turbidity and you under-inoculate, you're going to get a lower MIC. And that's been some of the question is, trying to get this as reproducible as possible. We also know some of these ESBLs are inducible. People look quite fine. The MICs look really low. You start them on a drug, boom, they do fine for 3 or 4 days, and then they get really sick because now you've turned on this inducible resistance. And finally, knowing the mechanism of resistance, it may not be as simple as we thought. And we may still need to see if it's an ESBL or if we see porin change and some other beta-lactamase going on. And those are really going to be, I think, challenging for us in the micro lab with all these different changes. So, the argument is, should we toss ESBL determination out and just go with the lower breakpoints? And Dr. Schreckenberger, in the presentation they sent, basically said there's no compelling reason to tell any laboratory that it's any better to stop performing ESBL testing. As a laboratory director, I'm bound by law, and that's CLIA law, and implementing methods of testing that assure the quality of every result that leaves the laboratory. In this regard, the best way to do that is combine the use of lower breakpoints with ESBL testing. So I think you're going to see a little still disharmony between lab directors as to what's going to be the best thing to do. And again, it does go back to what we've talked about a little bit, and some of these isolates are going to test susceptible to some cephalosporins and non-susceptible to others. You might have a cefotaxime MESBL that tests resistant to cefotaxime but susceptible to ceftazidime, and what do we do with that? And where's the MIC? And I think it's going to be interesting to see how this all plays out. Again, this was published not that long ago last year by Kroner et al. In Journal Clin Micro, and just looked at some of their data. And what you see is basically some of these, like cefepime, being a lot more susceptible if there is beta-lactamase around, and some of the other isolates, which are really more over on the percent resistant side, being very significant. There also are other issues that I think nobody has thought about with this, just to make this about as crystal clear as healthcare reform. That CLSI is recognized experts in setting the breakpoints and making sure that the breakpoints seem to be congruent with patient care. So putting basically not only in vitro, but in vitro. What happens to people that the antibiotic shouldn't work, but it does? And what about where the bacteria, or the susceptibility testing that it should work, but it doesn't? What are the mechanisms, and how do we get around that? The other group that sets breakpoints is the FDA. As a matter of fact, they set them. They haven't revised any of their breakpoints in the past. CLSI has. FDA hasn't. And if you have a commercial test system, you have to follow the FDA's breakpoints because that's what's approved by the FDA. If you change it, then you're out of compliance with the FDA. It's like being, if you will, off-label. So even the carbapenems were having a resistance, and the ones that are available you see listed here, and that's a problem with the newer thing over the last several years has been carbapenemase resistance. It would be nice to have a test that's easily ordered that tells you if that enzyme is present or not. And how easy is it to figure this out? As you said, some of you have sat in some of the meetings that we've had with the laboratory trying to figure out, because this is one of the National Patient Safety Goals the Joint Commission is looking at this year. Are you looking for this really more from an infection control issue, and how do you determine it? How do you know what's out in the environment to make sure people don't get this because of the problems in treating it? It's resistant. Some of these are resistant to all the carbapenems, so that you really have not much left. Maybe amikacin and perhaps colistin and something else. So this is going to be an issue, and sometimes that it's not all-encompassing. It works for some of the carbapenems, like ertapenem, but not so much for imipenem, and sometimes meropenem, sometimes not meropenem. So this becomes a real problem, and this is, again, from some of the CAP surveys that they sent out. And the number of test results that they found with a reference MIC greater than or equal to 8 being resistant varies, again, depending on the automated system with the same thing that we looked at before. So this is going to be a problem if the FDA doesn't revise their breakpoints, so we may end up still getting exactly the same thing, even though CLSI says that they should be lowered. And who's going to win? I'm not sure at this point. The confirmatory test that came out that the CDC and others were quite interested in with carbapenemase was using a modified Hodge test. Are you all familiar with that? Do you know about a modified Hodge test? I'll show you a picture of it in a second. If you look at procedures, imipenem disc testing is not a good screen. Meropenem MICs don't work as a screen for Proteus providentia morganella because the slightly elevated MICs are kind of inherent in that group. So that you can't use that, but probably the best thing to use that some people like is ertapenem, although in some people's hands, actually meropenem, if you truly wanted to see, meropenem would be the best thing. I think we use ertapenem because that's historically what people have looked at. But this is still up in the air. So what you do is you make a line, as you can see on that auger plate, and again, at a 0.5 McFarland, and it's a Mueller-Hinton auger. And using a standardized E. coli that you see listed there, you put a 10 microgram ertapenem disc right in the middle. So that's what you see with this one. Actually, though, close up, I see it looks like it's an imipenem, which is interesting. What you do is to take the isolates that you're interested in looking at to see if they're carbapenemase producing, and you streak them toward the disc. And that's what you're seeing with all these labeled A, B, C, D, and E. What you're looking for is if that isolate produces carbapenemase, because if it does, then this E. coli is going to grow towards the disc because now there's no inhibition from the antibiotic. So if you're seeing this growth in, kind of that finger projection coming in, that's the positive modified Hodge. The rest of these are negative. You just don't see them working with B, C, D, and E, but with A you do see a positive. Now you can imagine this is not easy to set up. It takes time. Somebody has to read it. So this is not laboratory and friendly to do this. And that's where that a lot of people, I think, are having some issues. So what they're looking at doing for carbapenems is from 09 to 10 is looking at finally giving us some breakpoints for doripenem. Ertapenem, that was at less than or equal to 2 and resistance being greater than 8 is going to drop to 0.25 and resistance being greater than 1. Since it is one that certainly gives you an idea if there's carbapenemase production around. Imipenem and meropenem are also going to drop from less than or equal to 4 to less than or equal to 1 and a 4. So basically you're getting, again, twofold, a 2 dilution drop. So they're saying, do you need to do all this if you're going to drop the breakpoints to do modified Hodge test and everything? And, of course, they're saying, well, no, not necessarily because we dropped the breakpoints and this should become less of a problem for you. The problem is, infection control-wise, this is a huge issue. If you don't have carbapenemase-producing organisms like E. coli and Klebs, you don't want them in your hospital, and how can you screen for them? How can you follow current guidelines that are out there? So if one thing changes, then a lot of things are going to have to follow suit, and I'm not sure that they're ready to do that. We would like to know what the resistance mechanisms are because they could be two mechanism resistance with carbapenem resistance. One is it's producing carbapenemase. The other issue is it can be making a cephalosporinase, and you can change the porins. You can lose enough porins so that you're not getting enough drug into the cell wall of the bug, especially these gram-negatives. So the effect is very similar. But this is not as high-level resistance as this is. So, different antibiotics might work. So if you had an AMP-C type beta-lactamases or certain ESBLs that are low-level carbapenemase activity and losing the porin is going to be a different mechanism. Are we currently looking for those? Well, we're not really set up to do it, but Sentinel Labs do this to give us an idea of what's going on around the country, and I think this is where that we're going to have issues. The bottom line with this, without reading it all to you, is that these are potentially, if it's not endemic in your hospital, and it's not, I don't think, in any of the hospitals around here, we've seen some issues with this, but not having 40, 50% of isolates having carbapenemases. So this, for us, is going to be a big deal. And I think I'm going to skip that because of time. So this takes us back to what we saw in the past and being discussed by the IDSA, of looking at this call to action in the medical community, because the antibiotics that we currently have are what we're probably going to have, especially with the gram-negatives, for quite a while to come, is that the microbes don't need us in coming up with ways to become resistant to antibiotics. They're good at that already, but we can facilitate that by using antibiotics unwisely and pressuring them into changing as well. So that's the whole issue for trying to come up with antibiotic stewardship programs, and I think you all know that we've done that over the last several months at the VA. That's still a work in progress, and starting to do that at Tampa General. All hospitals are going to be looked at by Joint Commission as what are you doing, trying to deal with these issues. And I think it's really now going to become somewhat cumbersome if the breakpoints change and things aren't as congruent as they used to be, because then what are we going to do? How do we know it's an ESBL? How do we know it's a carbapenemase-producing organism unless we ask the laboratory? And how's the laboratory going to accommodate that? I think there's still a lot of discussion that is going to happen for us to be really effective in doing this. The other is, as already mentioned, the 2009 National Patient Safety Goals that started this year, and the big one there is multi-drug resistant organisms. The next one that's on their screen, guess what? We've already been looking at MRSA. The VA has had a directive to do nasal swab screening and amplified testing for that, doing MRSA PCR swabbing on all admissions, transfer within the hospital, and at discharge or death, which is always interesting, which means that beside taxes, now you can't get out of this life without having your nose swabbed if you're in a hospital, at least at a VA. But Clostridium difficile is not necessarily a resistant organism, but I guess they have no other place to look at it, so that's going to be the next performance thing that is going to get a lot of attention.